say the U.S. healthcare non-system is for the most part a historical accident. The link between employment and healthcare and health insurance coverage came into being largely because of decisions made first during World War II about how to tax healthcare benefits, and then it was cemented in the 1950s. No other industrialized country links healthcare to jobs in the same way, and no other country covers or fails to cover its citizens in the same way. Largely as a result of the way we do health insurance and access, we have 47 million uninsured Americans and rising, many of them working Americans, as you know. For the self-employed, they have huge difficulties getting affordable coverage, either group coverage or individual coverage, and far too high premiums and coverage restrictions tied to that insurance. With rising medical costs, many middle-class Americans are facing medical bankruptcy, even if they have coverage, simply because of co-payments and other charges that their insurance does not cover. And because of the close linkage between a job and health benefits, the U.S. in effect has tens of thousands of mini healthcare systems run by employers, with people moving in and out of coverage and between insurers, often with little or no choice of the insurers they have. And this state of affairs is especially poor, as we'll hear later on, for those Americans with chronic illnesses like arthritis, depression, diabetes, hypertension, which may account for up to 70% of U.S. healthcare spending. And finally, because of this state of affairs, the government forgoes an estimated $200 billion in tax revenues because health benefits offered by employers are not taxable. This is the so-called employer health deduction, and this mainly and disproportionately benefits those at the top of the income scale. For these reasons and others, comprehensive health reform is at the top of the agenda in Washington, as it was, and as many of you are involved in California last year. And the New America Foundation has been very actively involved in both those debates. We'll hear briefly at the beginning of our session today from my colleague Michael Weinberg about the state of those efforts. Then we'll hear and have a chance to discuss at length from three leaders who've been developing novel and important ways to provide truly beneficial access to health care under the current patchwork system, while thinking about how to make the innovations they've pioneered commonplace throughout the medical system in the future. First, to my right, Sarah Horowitz, who's the executive director of the Freelancers Union, which is a nonprofit organization that represents the needs of America's independent workforce. She spearheaded the creation of this, the Freelancers Insurance Company, to ensure that independent workers in New York have stable, long-term access to health insurance, and is now working with policymakers across the country to try to bring this model to other states. Next to Sarah is Susan Ehrlich, the interim chief executive officer, sorry about that,
That's all right,
of the San Mateo Medical Center, who helped create its innovative care clinic. The clinic's integrated approach to the treatment of chronic illnesses seeks to improve health outcomes and quality while lowering medical costs in California. And again, to her right, and to lead our discussion today, Frank Mischke, the managing director of the Next Social Contract Initiative at New America. This initiative tries to find ways to link healthcare, education, savings and retirement policy, and workplace and family issues to build a platform for economic security and opportunity for all Americans. Before joining New America, Frank worked in many high-level positions in state government, including as director of state-federal relations for Massachusetts Governor Mitt Romney. Thank you, Frank, so much for being here and for your partnership on these issues in this conference. So without further ado, I'd like to call on Michael Weinberg to talk about the state of affairs in the health reform debate today.
Good morning, everybody. My name is Michael Weinberg, and as Leif mentioned, I'm a research fellow here in the California program. So I'm going to set the stage for you a little bit and talk about what's going on in Washington. For those people who follow this very closely, there might be some review, but hopefully I can add a little bit of value with some of my own observations about some things that we're going to be seeing come up on the agenda here pretty soon. In this talk, I'm going to kind of handicap the prospects for what I see as the possibility that we actually will get health reform in DC this year. It's not actually obvious that we will. To do this, I'm going to look at a couple of different things. I'm going to look at the action that's currently going on in the congressional committees that are leading healthcare reform, and then I'm going to sort of look ahead to the end game and how we might actually pass a comprehensive package that would come before the Congress. When I'm talking about Congress, a lot of people think, well, this is President Obama's plan, right? He talked about it a lot in the campaign, but President Obama and his administration are actually not currently leading the health reform effort. They've laid out a series of principles, but for the most part, they're deferring responsibility of this to the currently to the Senate, and specifically to Max Baucus, who is the chair of the Senate Finance Committee. Now you might ask, why finance? I thought this was Ted Kennedy's deal, right? Why isn't the Senate Health, Education, Labor and Pensions Committee the lead actor here? And the reason is because Senate Finance owns Medicare. And almost all of the major reforms that are going to be happening at the federal level, particularly the delivery system reforms, actually are under the responsibilities of the Senate Finance Committee. And even areas like the creation of a new insurance exchange that Ted Kennedy's Health Committee might take first stab at will have to rely on decisions that finance makes about the amount of subsidies that people are going to get to actually purchase insurance plans on this exchange. So that's something that I was kind of surprised initially to find out that finance was going to be the key player here, but in fact they are. And they have been playing. They have been on a forced march in the Finance Committee. Chairman Baucus's staff, ranking member Republican Chuck Grassley's staff, they had a roundtable last week that was on delivery system reform. Well, actually a couple of weeks ago. They came out with their delivery system proposals last week. This week they had their roundtable on coverage. They're going to have their proposals for coverage coming up pretty soon. Then they're going to look at how to actually pay for all this stuff, which, you know, they're looking at last, because I guess that's the most difficult thing to figure out. That's kind of the state of play of what's going on in finance. You know, Obama's going to continue to play an important role in framing these discussions, and he'll probably play an important role in stepping in to hopefully sort of bless the package that comes out of Congress and help give it that final push. But for the time being, it really is located in the Finance Committee, and these efforts are pretty bipartisan. Chairman Baucus and Ranking Member Grassley have been working very closely together, and even though Grassley kind of grumbles about various aspects of the plan publicly, as he sort of needs to do based on his political party, his staff has been working really closely with Baucus's staff for the time being, and that's it really is a bipartisan effort in the Senate Finance Committee. And they're going to be getting the estimates of how much their proposals will both save and cost sometime in the next month or so from the Congressional Budget Office. So if you hear about CBO scoring, all that means is that the office that's responsible for talking about how much we're going to save and how much it's going to cost is the Congressional Budget Office, and they make those estimates. Okay. So here's probably the most critical observation of what they've proposed so far, which is focused on delivery system reform. And that is that a lot of us in the policy wonk world are very concerned because the system we have set up right now is primarily a fee-for-service system. So whatever doctors do, they get paid some small fee for, and what this means, as you guys for the most part know, is that the incentive is to provide a larger quantity of care rather than a higher quality of care, rather than sort of efficiently using medical resources to keep people healthy, or even just focusing on keeping people out of the hospital at all. I mean, that would be the best way not to get a second heart attack is not to get a first heart attack, right? And the problem with that is that our whole medical system is set up such that there's a disincentive to keep people out of hospitals, right? The hospitals and the doctors and so on obviously have very strong professional obligations to keep people healthy, but unfortunately all the economic incentives are set up to conflict with those professional obligations. But what we've seen come out of finance has been not really an entirely new way of structuring these payment arrangements, but really kind of fee-for-service 2.0. where they're taking this system that we have concerns about and kind of layering on top of it various incentives, such as the, you can actually leave those off while people are talking at the, okay.
But from every spot.
Okay, well then just, all right.
I'll be quiet.
All right. Okay, excellent. So they're not really fundamentally changing this system. Okay. There's a pay for performance initiative, for example, but that's only going to put at risk 5% of doctors' payments for these performance initiatives, and that doesn't even start until 2013 and then is phased in over several years. So these are really very incremental approaches to changing how the delivery system works, and they're really not sort of fundamentally changing how we do payment in the United States. So on the House side, I'm talking about the Senate. House side's a little bit more complicated because Medicare has 4 different parts, and the Part A is belongs to the Energy and Commerce. I'm sorry, belongs to the Ways and Means Committee, chaired by California's own Pete Stark. And parts B, C, and D belong to Energy and Commerce, which is chaired by Henry Waxman. And I'm sorry, Pete Stark is actually the chair of the Health Subcommittee, but he owns Medicare Part A. And all of this sort of complicated congressional committee assignments are a little problematic on the House side, because what we ultimately want to come out of this is incentives that are all pointing in the same direction, right? So that hospitals and doctors all have the incentive to provide the highest quality care at the lowest cost. But if you have the Part A regulations that relate to hospitals coming out looking very different than the Part B, C, and D regulations that relate primarily to other providers, then you may not have a really coherent package. So it's going to be very interesting to see how the House proposals and the different House proposals well, I won't use that word yet, get put together with the Senate proposals down the line. One big area of contention has been this question of, is there going to be a public plan? Is there going to be a public option to compete with the private insurers in the new insurance exchange where people are going to buy their health care? And this is, Chairman Stark has made this his top priority. And last week, the heads of 4 different caucuses in the House said, which is about 100 different members of the House of Representatives, said, we absolutely want a public plan. We're willing to die on this hill. This is our biggest issue. We're going to go with this. And then this week, leaving the Republicans entirely out of it, 50 new Democrats, which is to say sort of moderate and conservative Democrats, came out and said, we actually want to create a system that builds on and improves private insurance rather than incorporating a public plan. So this is a ticking time bomb. It's ticking pretty loudly. I mean, we all know about it. But it's not really clear to me how this gets resolved, because not a lot of the folks have left themselves a lot of room to negotiate and say, we're going to take this off the table, or we're going to accept it when we've been loudly saying that this is a deal breaker for months and months at a time. So I don't know how we get out of this pickle, and this isn't the only pickle in the basket. So, looking ahead to the end game, the budget resolution that was passed a couple of weeks ago stipulates that we need to deal with healthcare reform before mid-October. And one of the things that we've been hearing a lot about in recent weeks is this issue of reconciliation, right? Is there another way that we can do this? Because the big problem is that if the Republicans filibuster it, we need 60 votes. And maybe we can get those 60 votes because there are probably going to be 60 Democrats, but not all Democrats are the same, right? And so you've got, for example, Ben Nelson of Nebraska. You've got newly minted Democrat Arlen Specter of Pennsylvania. And you can't necessarily count on all the people within the Democratic caucus to vote to shut off a Republican filibuster. So it would be great if we could use this reconciliation tactic. But, and under reconciliation, you only need 50 votes. It can't be filibustered, and it's a shorter debate. So the Democrats think, oh, this is great. We'll just use reconciliation. We can get 50 of us, right? There's 60. We'll lose a couple. The problem with reconciliation is that anything not directly related to deficit reduction is able to be challenged and potentially stripped out of the bill by the folks who have objection to it. So say, for example, Republicans. And I won't get into all the arcane details. I'd be happy to afterwards if anybody wants to know. But the last time these challenges were used, it was to successfully strike Medicare payment reforms from the Deficit Reduction Act of 2005. So exactly what we're trying to do and what Senate Finance has proposed is exactly what was struck out of bills the last time the reconciliation was attempted to be used. So I guess I wouldn't get, it's an interesting bargaining tool that folks are trying to use to get out of a hostage situation, but the metaphor that I've been using is that this gun that we're trying to use to get out of a hostage situation may not have any bullets in it. So that's just something to keep in mind on that. So the biggest issue is, if reconciliation isn't going to work, we're really going to have to bring along some of the moderate and conservative Democrats and maybe even some of the liberal Republicans. And what these folks are most concerned about is the total cost of the package. But the problem is that so far, any major proposals to save money in health reform or any major proposals to raise money to fund health reform have been shot down, right? Eliminating the employer-sponsored tax exemption, taxing charitable contributions, and so on and so forth. Every time that Obama has proposed some way that we're actually going to pay for this, people have said, absolutely no, you can't do this, and these are Democrats who are saying this. So it's really a cause for concern, and I don't want to leave you with too much of a dark picture, because in many ways the timing really is right for looking at health reform. There's a lot of energy and a lot of effort in the Congress. There's a president who's committed to it, but there are just a lot of parliamentary and policy barriers that we're going to be facing a few months down the line. So I don't want to undercut the extent to which the Finance Committee has proposed a lot of things that make policy wonks very exciting. I mean, when they put out their list of reforms, it looks very much like the wish list of pay for performance and all these other things that we've been promoting here in California, and that's all very exciting. But as somebody, as I mentioned, what they're really not doing is thinking very seriously about containing medical costs, or thinking very seriously about exactly how to really move us in the direction of better value for medical spending. And so as somebody who's organizing a task force on getting better value for medical spending here in California, they've left us a little bit of work to do. They haven't totally taken care of this at the federal level. They're not even proposing to take care of it for the most part. So as a concluding comment, I'll just say, it's probably better to think about what's going on in DC right now as health reforms, plural, rather than health reform. All these different financing changes and so on and so forth that are coming out of the Senate need not be linked together. And the good news is that individually any of these reforms will probably, in some sense, incrementally move us toward better value, somewhat expand the number of people who have health insurance, and so on and so forth. But to kind of bring in something that we've just said, we already have a non-system in the United States, right? And that's essentially the problem. The problem is that the system's so enormously complex that it's impossible to understand, and it's impossible to get a handle on, rampant inefficiencies, very low value for our medical spending. And so what we're sort of proposing to do is layer a number of sort of incremental reforms on top of this non-system that we have. So it's not clear that that's how we would get ourselves to a coherent system with better value for medical spending. But I think that a lot of these reforms in isolation are worth looking at, and it's going to be it's a really interesting time to be doing health policy work. I know you folks probably are, and I'm going to be following what's going on in Washington real quickly, and I'm happy to answer any other questions later on during the event. And now I'd like to turn it over to Sarah Horowitz, who will be talking about her innovative work in New York.
Okay, after much deliberation, I have decided that Susan is going to turn my pages. Can we just move this around? Will that be okay?
So this is right. There's a. That looks. I don't know if you're looking to the left and see that. There we go.
Okay, I don't want to say anymore. There's a little wetness down here by the electrical cables, but
It's just a little wetness.
All right, we're gonna test the healthcare response
I'm
model
going
right
to
here.
just touch whatever is plastic around me. Okay. This is going to be on YouTube after all. Let's make it interesting. So, I think I can say good morning, but being from New York, I feel like I really want to say good afternoon. So let me just say I'm going to talk about 5 things today. One is the background of what I do, who am I, why am I here, chatting with you, and a description of our model at the Freelancers Union. That's going to be the bulk of my talk. Then introduce this concept of a civil society hub and hopefully get into some discussion about that. Talk a little bit about this idea of where are we going in this health reforms discussion about exchanges, and then just sort of like thoughts about California, and we can just riff off that last one. So what I first want to do is go over with you, thank you, just before getting into what is the Freelancers Union, just think about the way that we have sort of in the way we think in our minds about work. We tend to think about that little red as the workplace. Maybe it was a college, maybe it was a factory, maybe it was a university, but it's a place where people went and they worked in the long term, and the people who worked there were full-time employees. It's in the little stick figure, and those people had jobs. And as a result of 1, having a job, and 2, being an employee, you got access to health insurance, retirement, unemployment, the right to unionize, a career ladder. And if you really think about it, so now think what's in that black square, the blue square, that's really the New Deal. And what we did is we said in the 1930s, the New Deal was going to attach to people if 2 conditions were met. That is, they were full-time employees, and those employees had jobs. Next. So now you think, on the next slide, thank you, that this is really the way work is. It's these little interesting little shapes, and people are now very much more going from job to job and project to project. And instead of having these full-time jobs, they tend to have more like gigs or part-time work. And instead of being employees, they're either independent contractors, and I usually do this kind of Socratically and make people, I call on people, but you know, it's California and it's like laid back, so I'll just do it myself. But if you want to jump in, just jump in. So independent contractors are freelancers, consultants, self-employed, or they're short-term employees, that is that they're part-time or temporary. So remember, what did we just say about the blue box and the New Deal? There were 2 conditions that had to be met to get access to the New Deal. Sorry, I thought I turned that off. Okay, so what was it? You had to be a
full-time
employee, and what else did you have to have?
a job.
A job. Okay, so now if you're an independent contractor, how do you not fit?
You're full-time, not a job.
You don't have a job, and you're not an employee, or you have a short-term engagement which doesn't enable you to get these benefits. You answer my phone, you do my slides, sorry about that. Next slide, okay. Here we go. Yes, thank you. So that first part was the background. Now we're going right into the second part, which is the description of what we do. So the Freelancers Union has a model where we bring together independent contractors, self-employed people, part-timers, and we group people together and provide advocacy, information about gigs and work, events, and we provide health insurance, a freelancer 401k, which is a group 401k. But this is the model that we bring people together in a platform. And if you could just go to the next slide. in a quick rundown, we provide health, dental, disability, life insurance, the 401k, financial career education, different kinds of discounts, and then a lot of social networking. We've started a PAC in New York City. We're starting a federal PAC. And the idea is that we model the social safety net, and then we engage politically with elected officials to start talking about how are we actually going to implement those changes so we can do a full circle or cycle or something like that. And so next slide, we have 110,000 members nationally, and we predict very conservatively 135,000 by the end of the year. Next slide, thanks. If you look at the income of our members, and this has been something that has been pretty shocking to me. I started this 13 years ago, and whenever we were looking at our numbers, the biggest income group was between 25 and 50,000, and the next was 50 to 75. But what you can see that since really the fall, we now have 27% are earning under 25,000. So we're really seeing that this group, remember back to the blue square and the New Deal safety net, what's happening is, just think of this way. How many people here have ever freelanced, first of all? Okay, so the rule of thumb that if we went around the room and talked, what are your coping strategies and how do you do it, is for every dollar, I put 60 cents into a checking account and 40 cents into a savings account. The 40 cents, I'm not looking for any return. I just want liquidity. I want to get it when I need it, and I'm going to use it to pay the taxes and the benefits. What we're finding that is happening with freelancers now is that they've gone through their 60 cents. They're either working less or not working at all, and are now going through the 40 cents. And when they go through the 40 cents, now, because we're in the state capital, go through all the programs in your head, as I do when I'm at member events, and I hear people telling this, and you realize they're going on welfare. Because 0 to 60, we have nothing for a third of the workforce. Part of what led us to do what we do is looking at what happens to independent workers, focusing on New York, but this is happening nationally, is that people are regularly experiencing gaps in their coverage. So 15% have no coverage, 32% have gaps in coverage, and only 54% have had full coverage. So now, if you go to the next slide, you can now see we have these members, 110,000 members. The number one issue for members is getting health insurance. We started grouping people together, but we had to put all our members into like one bucket within the insurance industry, and we weren't able to innovate on the things that our members really needed. So for instance, we've been having members in a group since, let's say, 2001 in our current model, and we know that our members use a lot of mental health services and a lot of pharmacy. And our goal is not to get our members to use less, but to figure out how can we start looking at what are the things that people are going to need. Just the same as the United Mine Workers probably has to think about a lot of illnesses related to people's lungs, or there must be another thoracic issues or something. Pulmonary issues. Clearly I'm not a doctor. And so we can then start really thinking about what are the innovations. But because we had to always partner with traditional insurance companies, we weren't able to start thinking about what will be the next kinds of innovations focused on our members. So again, back to the blue box. Not only are individuals stuck in a kind of 1930s workplace, but so too are regulations. So if, let's say, we were a large employer, and I'll get to how many numbers we have in a second, we would be self-insuring. It'd be kind of a no-brainer. It wouldn't be hard. Every large company, for the most part, and all that means is a large company collects the premiums that you would normally pay, and I'll just make up the numbers to be simple, let's say $200 a month per employee per year. And then when the employee goes to the doctor, they just take out of that bucket and pay it back. And on top of that, they put something called reinsurance just on those times where there was too much medical use over the amount that was collected. But because we're not, we don't fit into the 1930s framework because we're not a large company, we had to start an insurance company. So the Freelancers Union then started its own company, and we raised $17 million from Ford Foundation, Rockefeller Foundation, Robert Wood Johnson. I like to say we raised $17 million of nonprofit money, which is $150 million of dog regular money. You know, like, get it, Silicon Valley. Anyway, okay, so now here we are in New York with our model. We now have 20,000 people who we cover in our freelancers insurance company. By the way, the individual market in New York is 100,000, so we're already at 1/5 of the entire market there. Give you a sense of, I'm just going to breeze through these, but if people are interested, we can go over it. We offer 5 plans, ranging, and on top of that, freelancers, because so many people raise their hands, we always get like the worst insurance companies to partner with, and you all know what I mean. It's like the ones that suck. And so what we were able to do was we then finally were able to work up the food chain and partner with Empire, which is Anthem and the Blues, so that in New York now freelancers can get access to the best network in New York and are getting the best rates. So freelancing in New York City is actually, I mean, people have problems, don't get me wrong, but we've been able to start really making something that's in the realm of affordable, even in the worst of times. So our most comprehensive plan is $460 for an individual, then $320, $235, $215, and $149. Even the high deductible $149 is with the Empire Network. And the HD 5000 will be an HSA starting in January. So these very colorful slides show that what you'll see is 1/3 of our members are over 40 and 2/3 are under 40. And the male-female thing is always so interesting because it's always 50-50 and it never really changes. I don't know why that is. A little bit more male, a little more female, but always 50-50. These are the top industries in New York. And what I think is really interesting is, though we're talking about this new, we're talking about healthcare today, what I think we're really talking about, and a lot of this about healthcare reforms and other discussion, is really what's happening in the broader economy. And so really, I think when we talk about health insurance, we need to look at it as a frame of what's happening to the working middle class. And when we think of middle class in New York City, and I'm sure it's the same in California, when you hear elected officials speak, this is what they always say. They say, we're here to protect the middle class, cops, firefighters, and nurses. And so my personal goal is that I want one of them one day to be like, nurses, firefighters, programmers, graphic artists, and domestic workers are middle class. And so you can see that for us it's film and television, advertising, but it's also financial services, healthcare and alternative healthcare, IT and other, education. And so it's really the growth industries in New York which tend to be the ones where you see a lot of freelancers. It really dovetails a lot with Richard Florida's work in the creative class, but I think one thing that you see, and you see it in California, is wherever there are those pockets of intense amounts of economic growth, we are seeing freelancing, and that's another discussion for another day. So that is the second part, the description of our model, and we can go into that in the Q&A. Now I want to talk about civil society hubs. Because one of the things that I'm most concerned about in doing the work that I do is that we have gotten to a state where I think individuals have inadvertently, and I say this respectfully and lovingly in California, have internalized Ronald Reagan's worldview. And the worldview is that we are all atomized individuals. And whether we're on the left or the right, that's what people believe. So you have people who want single payer, want to have an individual, get their insurance from the government. Others, potentially more on the right, want to see individuals getting insurance from the insurance industry. And now just like play this out in your mind. We've now succeeded and we are a society of individuals. And now somebody calls up an insurance company and is like, you know, I'm having like a problem with my claim. And they're like, yeah, huh? What? Okay, yeah, Click. Okay, and then the same way, I'm having a problem with my government-provided plan. Who's like my rep? They're like, you're a rep? What? Yeah, click. Okay. Now, if you can imagine another conversation, which happens to me sadly and happily, is a member calls up and they say, you like totally messed up my plan. Then they go on to member chat or on our site, they really messed it up, they drive me crazy. And then other members come back on the site and they're like, you too, me too. So then I, being a human being, I'm like, oh my God, run over to the director of operations. I'm like, what is going on? Like, and then we can see, is Mary Jane having an isolated problem? Or is there like a systemic problem where we're screwing something up really in a big way? And we're beholden because they're our members. So if we do a bad job, they're going to leave. Or if I do a really bad job, they're going to get rid of me. And so I think we have to work away from this idea that we're going to come out of here as isolated individuals and start going back to our traditions in America of de Tocqueville, you know, these ideas of voluntary association, mutual aid associations, cooperatives, that people are already organizing groups around faith-based stuff and community groups and unions, and that we don't have to say those groups all kit and caboodle are going to do everything, because maybe there's some groups you don't want to be doing some of the financing, but they know their people and they know their markets, and they should be able to be doing some of the marketing and other pieces. We should be having a universal financial system because that is the role of government, but maybe there are other things that we could be thinking about. And so what I really hope is that as this is the first stage of health reforms, and there's only so much that we could do in 2009, but that we start saying, wait a minute, let's view that as a beginning and not the end, and realize that there's a big structural change happening in America, and we need to be thinking about the groupings that can play a role in democracy. So remember we said, what are the things we offer? Well, it's health and dental and disability. Well, we also have a PAC, and we have one in the states and federally, and so that you don't want to create something like a welfare system where once an elected official comes in and can cut it, doesn't have the same membership groups like an AARP that can beat something back. And I think if you look from a public policy perspective, one of the only groups that has been successful in beating back any of the attacks on social insurance in any way has been AARP, and not coincidentally, 1 out of 2 people over 60 is in it. And so we need to be having membership organizations and not think of ourselves as like recipients. So think of that civil society hub, and if you can come up with a better word, tell me. Now we're coming to the fourth part, and these parts are really short. So now, if you think, I think there are 2 good examples to think about. The FEHBP, does everybody know the Federal Employee Health Benefit Program? Who said that? Because it's smart. Okay. And the Massachusetts Connector. Now, smart person there in that blue shirt.
Yes.
Can you explain how people get into FEHBP?
Yes, they have to be a federal employee.
And as a federal employee, what's the entryway in?
The Office of Personnel Management.
Okay, and what entity must they belong to? Who's the grouping that organizes that beyond the federal government?
Well, FEHBP has a variety of organizations that sponsor health plans. Many of them are unions.
Yes. Okay, so
some of them are just freestanding organizations, like the government employees have the Hospital Association. Historically, it was not a union per se.
Okay, so
but they do require membership, I think, which is where you're going.
Yes, thank you. So, and for the record, we don't know each other. And so, what's interesting about FEHBP is that it is a perfect example of a civil society hub, which desperately needs a better name. So, really, again, anybody has a good name, let me know. But they group people together, and they become a group of groups. So if somebody's having a problem, they're not like, oh, hi, federal government, I'm having a problem over here down in D.C. or Maryland or Virginia. They're like, I'm a letter carrier. Hello, president of the letter carriers. Is there like somebody who's in benefits administration? And it's an example where it's not just the employer. The employer is an important way to group, and I don't think that we have to like throw the baby out with the bathwater. If the employers are grouping and it's working, people should be able to get it from their employer. But if it's not, we should be having portability and seamlessness, and FEHBP really shows that. The connector, on the other hand, which is I think a very good and interesting and innovative thing, but I call it version 1. So look at the way you have to get into the connector. Individual or family. Okay, well now we're a group. Okay, we're like the California New America meeting group. That we all just became a group and we're group purchasing together, okay? Can we get benefits from individuals and families? Only as individuals, but as a group, can we get in? All right, what about young adults? Okay, I see like a couple of young adults. How many young adults are you? Raise your hand if you're under what? 26. Okay, so a handful of lucky young adults just got in, but did our group get in? Employees. Are we employees of our group? Are we hiring? Who's our boss? Group here. We don't have a boss. We don't have an employer, so that doesn't help us. And is anybody here a broker? Okay, so we have a broker. He can get 4% of total premiums. So, what's that?
7 in California.
Well, first of all, put that down for first step of regulation. That's way too much money. So, as you can see, there's no entry point in. We don't, as we're imagining our exchanges, we have completely forgotten these badly termed civil society hubs. And that is a mistake, because as soon as we put everybody as individuals, what are the things that people are going to say right away? You're having that problem, I'm having that problem. They're going to go to the very groups that they're already connected to, and we're going to logically have to go there anyway. So if we know we're going to go there, why don't we anticipate in this model that we need to be thinking about these next kinds of groupings? So with that, let me end. Thank you. And thank you.
Yeah, Susan, I was going to say, let's check, because it's almost noon, we'll just have people grab their lunch and let you get set up. And the food is served at the back, and then we'll keep the presentation going over lunch.
I will.
That was great, Sarah.
Except for the phone.